So next in our series on treatment, we're going to be talking about pharmacotherapies. So just as a reminder, pharmacotherapies are drug-based approaches to substance abuse. And most of the pharmacotherapies that we'll talk about actually fit in to treatment on that falls under that belief that um, drug dependence is a brain disease. That it is there's something different about the brains of people who become dependent than the brains of people who are not. So this approach supports the idea that by being able to change brain chemistry, that we'll be able uh, to treat that idea of abuse or addiction. Now, many experts in the field do believe that by using these drugs alone, we won't be able to fix the problem. If we think about substance abuse as a behavioral disorder, possibly as well as a brain disorder, then we're talking about an entire lifestyle built around the idea of using, and that we won't be able to use a single drug to address all of the factors that go into the choices that lead to that lifestyle. But the role of pharmacotherapy here would be to provide a window of opportunity to give those behavioral or psychosocial approaches to begin to work. So if we are able to relieve the withdrawal symptoms, then we can give the person a little bit of space to start making those changes in their lives. So there are two separate places where we can see pharmacotherapy becoming useful. And the first one would be during the detoxification or detox phase. So detox is going to be an initial and immediate result of stopping the use of the drug. And the role of supportive drugs in this phase is to alleviate the symptoms. Some of the withdrawal symptoms that a user can experience are extraordinarily uncomfortable, unpleasant, and even dangerous. So the role of pharmacotherapy here would be to relieve those symptoms so that the person doesn't feel compelled to go back and start taking the drug again, just to relieve the pain and discomfort of detox. Some of the medications that are used in the detox phase can be also used in the maintenance stage, and that's the next phase that we'll discuss for pharmacotherapy. So the maintenance phase, this is longer term. This is where the person has made it through the immediate consequences of stopping the drug. They've made it through withdrawal and detox. And during maintenance, we're looking for drugs here that would help the person to avoid relapse. So the kinds of approaches that we use for pharmacotherapy during maintenance are going to fall into three general categories. The first is the agonist or substitution therapy category, and then antagonist therapy, and then finally punishment therapy. We'll talk about each of those a little bit more. So for the agonist therapy, the role of the pharmaceutical here would be to induce cross-tolerance to the abused drug. So some examples here are methadone for heroin dependence, or nicotine replacement for tobacco dependence. So the person is able to experience some of the results that they expected from using the original drug, but in a less dangerous environment. Or with less dangerous consequences. So for our next category, antagonist therapy, this is going to actually block the user from experiencing the effects of the abused drug. And a good example here is naltrexone. If a person is on naltrexone, if they do take one of the opioids that they were formerly dependent on, they won't really basically want to experience any effects at all. So it blocks the effects of the drug. And then finally, there's punishment therapy. And this produces an unpleasant reaction if the person ingests the abused drug. And an example here is one that that has been used for people who are recovering from alcohol dependence. And the role of excuse me, disulfiram is actually the person who, you may know it by its trade name of antabuse. If a person is taking that pharmacotherapeutic drug and consumes alcohol, they become extremely nauseous. So it doesn't block the effects of the drug, but it does cause a very unpleasant side effect, this idea of punishment for consuming the substance. So first we're going to talk about the role of pharmacotherapy in alcohol. So during the detox phase, alcohol withdrawal can be actually very, very dangerous. It can involve everything from tremors to irregular heartbeat, insomnia, hallucinations, seizures. For a person who is a very heavy alcohol user, the withdrawal syndrome can be very, very serious. So because of these medical risks, a person who's going through alcohol detox often does this in an inpatient medical setting. Well, I guess in the best of circumstances. So one of the drugs that can be used, or one of the classes of drugs that can be used during alcohol detox, are benzodiazepines, or BZDs. So these actually hit the same receptors as the alcohol does, and they're able to reduce the unpleasant side effects, and sometimes even really dangerous side effects of alcohol detox. Now, in the maintenance phase, we've got antabuse, which we just discussed a few minutes ago. It causes those unpleasant symptoms of nausea and vomiting if alcohol is consumed. There's also a role for naltrexone here, and its role is going to be to reduce alcohol craving, and has been associated with reduced rates of drinking and relapse. We're not entirely sure how it works, but we think it works by blocking opioid receptors, which then inhibit the reinforcing effects of the alcohol. So a couple of different substances that we can use during the alcohol maintenance phase. Next, we'll talk about nicotine. We've got a lot of research in place for nicotine, and we've got drugs that are used both for detoxification and for maintenance. Nicotine withdrawal symptoms, while unpleasant, are not as dangerous as alcohol withdrawal symptoms. Nicotine users frequently experience anxiety, depression, sleeplessness, and then cravings for more cigarettes. So we do see an increasing role over the past decade or so for nicotine replacement products. These are the patches, the gums, the inhalers, lozenges, and these have all been shown to increase quit rates in very well-designed studies. So in the controlled studies, environments in which those studies took place, they were highly effective. Now in the real world, they're probably slightly less successful, but they still do seem to be able to support higher quit rates in people who are able to use those nicotine replacements. And then from the prescription drug front, a pharmaceutical called bupropion, also known by its trade names of Zyban or Wellbutrin. This has actually nothing to do with, contains no nicotine at all. It is actually a drug designed for mental illness or mental health and mental illness problems. It's also used in the treatment of depression, but it has been associated with decreased cigarette cravings in people who started out taking it for depression symptoms. So we do see some use of bupropion or Zyban or Wellbutrin, in that setting to assist people who would like to stop smoking. Another category of drugs that we can talk about here in that pharmacotherapeutic setting, opioids. So people have been developing dependence problems with opium for a very long time. And in the 1800s, in the early 1900s, when people became dependent on opium, the onset of withdrawal symptoms during the detox phase can be very, very violent. Extreme pain, extreme nausea, very difficult phase to get through when someone's trying to stop using the drug. So historically, a category of drugs called anticholinergics were used, and basically they were early anesthetics. So they would put a person into a state of what they called delirium, so they were disassociated from the external world, so they basically wouldn't remember what they went through. We use kind of a similar approach, but with different drugs, where a person who is dependent on opioids is subjected to anesthesia for the earliest period of that opioid detox. And they may also be given one of those antagonist drugs that basically causes immediate withdrawal. So then, after the anesthetic phase, the person is released. This would last about 24 hours. And then while continuing to take that antagonist drug, they would be able to go through a period of counseling. So the goal of this approach is to relieve the person of those very, very unpleasant and even dangerous symptoms during withdrawal, and give them that window of opportunity when they can use counseling to start to make some changes in their lives. This approach is subject to some criticisms, and there are some risks in that rapid withdrawal process. It's not consequence-free. And of course, an important component of the treatment as it's designed is that counseling, the behavioral and psychosocial changes that need to be made, but they aren't always emphasized in the process. So, a little bit more about opioids. We talk about those symptoms during the detox phase: nausea, vomiting, diarrhea, aches, but sometimes even really severe pain. Some of the specific drugs that are used during this phase include methadone, which you may be familiar with, and that works in that agonist mode, where it hits the same receptors as the opioid, but without all of the side effects that a user associates with opioid use. And then buprenorphine, this one's actually a partial agonist, so it has a more mild effect and actually has kind of a ceiling. It is still possible to die from methadone use. It's much safer than opioid use, but still has some risks. Whereas buprenorphine, it has a kind of a ceiling where the effects wear off. So it still has it still can have that effect where it just depresses respiration, that sort of thing, but not as dangerous. So both of those possibly used during the detoxification phase to alleviate the symptoms of withdrawal. And then methadone, actually very commonly used during the maintenance phase as well. Methadone maintenance may continue for months or even for years for an opioid user. Um, and we are just beginning to use buprenorphine for maintenance, so we don't have as much data available yet because of its more recent approval. So when we talk about opioid antagonists, so this is that pharmacotherapeutic drug that actually blocks the receptors. Naloxone and naltrexone are the two that we'll talk about for opioids. Now, naloxone is short-acting, and it's the one that's used to treat opioid overdose. And if you've ever seen it used, it can actually have it almost looks like a miraculous effect because it takes the place of the opioid. It blocks the same receptors that the opioid would be using, and can cause really dramatic reversals of its effect. When we talk about longer lasting effects, then we're talking about naltrexone. And that one is actually more useful in treating opioid dependence. Now, because opioids are so very highly addictive and dependence inducing, it can be effective, but it has to be a particular kind of individual, usually a person who's highly motivated to quit. We have some new formulations that are being studied, a once a month form that a person wouldn't have to remember to take every single day or even multiple times a day. And the initial findings from that have been promising. So some possible improvements for people who are looking for a pharmacotherapeutical approach to opioid dependence. When we talk about cocaine and trying to quit cocaine usage, the withdrawal symptoms that we'd be trying to counter there, depression, nervousness, loss of pleasure, fatigue, irritability, sleep disturbances, cravings. And if we can get a person through that initial withdrawal phase, their chances of successfully quitting can be the highest. So that risk of relapse is definitely the greatest during the immediate withdrawal period. And we suspect, because we're not entirely certain about what the effects of cocaine on the brain are, we believe that reduced monoamine neurotransmitter activity is what's underlying those withdrawal symptoms. So if we can treat that, then we may get the person through the withdrawal phase more quickly, more easily, and prevent that greater risk of relapse during that period. So what researchers are working on are medications that increase monoamine neurotransmitter activity during that time period. Unfortunately, they have not yet found a useful formulation, so we're not quite entirely sure whether we're barking up the wrong tree or if we just haven't found the right solution. But currently, we do not have an approved pharmacotherapeutic approach for cocaine dependence. Now, for marijuana, we do have withdrawal symptoms for marijuana: irritability, anxiety, sleep disruption, and some aches that are associated with that phase. And there's been many medications that have been tested for relief of those symptoms. Dronabinol is the one that has been found effective, but it's not currently a recommended approach. So that's basically our list of pharmacotherapeutic approaches for drug dependence. It's not terribly long, but something to think about is that when we talk about treatment for dependence here in the United States, 97% of the people who enter treatment enter for just 5 drugs. our classes of drugs: alcohol, opioids, marijuana, cocaine, and stimulants. And we talk about stimulants, we're primarily talking about meth. Now, the average age of those who are admitted is 34. Think back to our previous lectures this week on prevention and how we focus on school-age children. But the average age of people who are going into treatment is 34 years old. So we definitely have some younger and some that are quite a bit older. We look at where people are treated. More than half are treated as outpatients. 20% are treated as hospital inpatients, and this is typically during the detox phase, especially with alcohol and opioids because of the pretty severe health risks that can be faced. About 17% that are treated in residential settings, and then 6 that are in that medication-assisted opioid programs, that rapid opioid detox program that we talked about. We took up where treatment in the U.S. would like to go, where we would like it to go from a research perspective. We'd really like to see substance abuse treatment programs that focus on more effective interventions for our most commonly abused drugs, and for treatment that's able to be delivered on an outpatient basis, because more than half of people who enter treatment are in outpatient programs. So if we're looking at overall success, we'd like to be looking at the 5 most common substances and a treatment that's delivered in the most common format. So what we're really looking for is effective outpatient behavioral psychosocial interventions. And if we can get those going, then we'd be able to improve the overall success rate of our treatment programs. So back to our initial question, whether treatment is effective. And basically, we need to look at substance dependence as a chronic illness. We wouldn't take a person who had a heart attack, give them an initial treatment, get them out of the hospital, and let them go. We continue to follow up because we consider that a chronic condition. If we use that same kind of mindset to talk about substance dependence, we might help to understand why we don't have the same treatment approach that works for every individual. And even if we found one that works for an individual, it may not work every time. We may look at really requiring a continuing approach to care for that person throughout their life. But when we do that, when we're able to effectively help someone, it really is cost effective. It can be very difficult from a public health perspective to put a cost on, or to attach the benefits to the cost that we put in. But with the work that's been done in substance abuse treatment, we've been able to report a 7-to-1 ratio. So for every $1 that we put into treatment, that we save $7 in terms of reduced crime and increased employment. And then also from a public health perspective, we're also able to look at just saving lives. So some ways that treatment can be truly effective when we look at the ways that we can approach treatment here in the United States. So that wraps up our lectures on treatment, and let me know if you have any questions. You can always reach out on the discussion forums through Web Campus.